All right, good evening, everyone. Thanks for joining us. This is going to be a really engaging presentation. I know I'm really looking forward to what we have tonight, and I hope you all are as well. I want to tell you a little bit about the League. I'm the president of the local League CARE, League of Women Voters, Austin area. We are a nonpartisan political organization. We encourage the informed and active participation of citizens in government, and we influence public policy through education and advocacy. As a nonpartisan organization, we don't support or oppose any political party or candidate, and we provide nonpartisan voter resources like the Voter's Guide and vote411.org. So as a reminder, of course, I'm sure you are all well aware that early voting is open now and will be going on until the 30th. So go to vote411.org and you can pull up a customized ballot based on your address, see all the information there, what races are going to be on your particular ballot based on your address. If you're going to be voting on any propositions, you'll see explanations of those there as well. So please use that valuable resource, print out your selections, take them with you to your polling location, and make sure to vote. Tonight for our presentation, if you have any questions, please put those in the chat. Mary Cullinane will be monitoring that for us. And if you do have a specific speaker that you've got that question for, make sure to note that so she can direct that to the speaker that you have the question for. Mary and Leah are also going to be our timekeepers tonight. And Leah, I'll go ahead and turn it back over to you to introduce our guests. Thank you.
Okay, great. Thank you, Mariah. And welcome everybody. I'm Leah Masiello, VP for Programs, and our programs are part of our advocacy and education of voters. They help to make more informed voters. That's our goal. And I thought that these three people who are our panelists this evening would have some important information to help us think about the COVID-19 pandemic and about the treatments and vaccines that are being developed. So at this time, I'm going to turn it over to Mary Cullinane, who's going to introduce Dr. Wong.
Okay, well, I just wanted to say a few words. I'm a retired public health nurse, and I worked at Austin Public Health like 30 years ago. And, you know, in the early 1900s, almost 20% of children did not survive until their 5th birthday. And today, we just expect kids to be healthy and safe and to thrive and to grow up. And it wasn't because of medical care. Medical care is a small percentage of overall well-being. It was a lot of the strides that were made in public health. And one of those was vaccination. And even though we've made a lot of progress over the last century and a quarter almost, there are still persistent disparities and inequities that plague our society and our people. And so public health has taken different approaches to try to even that kind of stuff out. And I'm really excited to hear from our other two speakers, besides Dr. Wong, about how people are taking steps to rectify that. But I'm really pleased to introduce Dr. Wong. I had the good fortune to work with him for a few years, and I consider him one of the best docs I ever worked with and a true dedicated and passionate public health and patient advocate. He's been the director of the Dallas County Health and Human Services Department since February of 2019. And prior to this, he served as the medical director and the health authority at Austin Public Health, our public health department. And before that, he was the Bureau Chief of Chronic Disease and Tobacco Prevention at the Texas Department of State Health Services. He graduated in civil engineering from Rice, and his MD is from the University of Texas Southwestern Medical School, and he completed his residency here in Austin at Brackenridge. He has a master's in public health from Harvard with a concentration in health policy and management. And while he was at Harvard, he led a successful effort to divest their holdings in tobacco. And ever since then, he's been on a mission and a tear. And, you know, all the signs that you see in parks and public places, those are pretty much his handiwork. And when I see those when I'm with friends, I tell them, you can thank Dr. Wong for this. He's currently an assistant professor with the University of Texas, Dell Medical School, and the University of Texas Public Health. So he's not very busy at all. So thank you so much for joining us tonight. He's going to talk to us about vaccinations, and I'm just going to turn it over to you.
Thanks, Mary. It has been great working with her over the years. She's been, again, through multiple settings, we've had the opportunity to work with each other, and I've really appreciated that throughout the past years. But so Mary asked me to talk first, sort of provide some of the baseline about vaccines in general, then some of the things that are going on with the development of the COVID-19 vaccine. So again, I think I'll just start with, can you all see that? Does that work? Yeah, okay. And I don't know how you get rid of this. Let me see. How about that? Is that better? Does that work? So just as Mary sort of laid the foundation, immunizations, you know, are really a public health success story. And I'm going to start out again just with some of that history that Mary alluded to, because, you know, some of us, but many of us don't realize all the history of vaccination. You know, why do we vaccinate? And I start out a lot of times with these talks with a quote from a book by Richard Rhodes, A Hole in the World. And he talks about that when he was growing up, I guess, polio was a plague. One day you had a headache, and an hour later you were paralyzed. How far the virus crept up your spine determined whether you could walk afterward or even breathe. Parents waited fearfully every summer to see if it would strike. One case turned up and then another. The count began to climb. The city closed the swimming pools, and we all stayed home, cooped indoors, shunning other children. Summer seemed like winter then. And you know, there's a picture here of all the kids in the iron lungs, and I don't know how many of us on this call or on this, you know, Zoom ever actually saw an iron lung. I saw one. Actually, one patient was taken care of at Children's Hospital in Austin, but you know, we don't see these anymore. We don't. But that description, to imagine, and again, I don't know if anyone in this call experienced that. But that, to imagine how it was, and it's sort of some similarities to now what we're experiencing with COVID, but you know, that fear of going out, and you know, again, it's like history to us, but we don't really understand it. This is just some data. The number of polio cases, again, you know, 1937 to 2013. I mean, we got almost 60,000 cases a year. You know, this is right before then the polio vaccine was introduced in 1955. That year, there were 13,850 cases of paralytic polio that year. And you look at after then the vaccine was introduced, just the dramatic reductions and elimination essentially of polio. This is number of polio deaths. I mean, this one year before the vaccine, we had over 3,000 deaths in the United States from polio. The vaccine's introduced, and again, the just dramatic declines and essentially almost elimination of polio. Measles, another highly contagious respiratory virus, you know, spreads through the air, through coughing and sneezing. It's so contagious, after an infected person leaves a room, the virus remains viable for up to 2 hours on surfaces and in the air, and it spreads so easily that if one person has it, that 90% of the persons close to that person who aren't vaccinated or otherwise immune will become immune. You know, so that's almost our gold standard for highly transmissible infectious diseases. Again, measles before 1963, estimated 3 to 4 million cases each year in the United States, with more than 500,000 cases reported annually, 48,000 hospitalizations. 4,000 cases of encephalitis, 450 to 500 deaths each year in the United States. The vaccine was introduced in 1963. You can see, again, this dramatic decline. I mean, before, the number of cases in the United States in thousands, over almost 800,000 that year. And then after the vaccines introduced, just dramatic drops in the numbers. Just a slide about herd immunity. That's some discussion about that even today related to COVID-19. Just the principles on this first top slide here, the top sort of bar or rectangle, where the persons in red are those who aren't immunized and sick and are sick and contagious. The persons in blue are those that aren't immunized but are still healthy. And then the persons in the greenish yellow are those that are immunized and healthy. And you can see on that top bar that if you start out with just a couple people sick that aren't immunized and everyone else in the blue who's not immunized but still healthy, then everyone winds up becoming sick and red, sort of on the right-hand side of that. In the middle section, you can see if you've got a few people who are immunized and healthy, the yellow-green people, and then, but most of the people are still not immunized, but still healthy, but then you get a couple sick people, then still almost all of them wind up going to red and becoming sick. But if instead on that bottom section, if you have most of the people who are immunized and healthy, and just a few people who aren't immunized, then if sick people get in that, they protect some of those few people who aren't immunized, and that's the herd immunity. But in the discussions regarding COVID, herd immunity is not letting everyone get sick. It's not that first scenario that we're going to let everyone get sick and turn into that red, mass of people on the right side. The herd immunity is from vaccinating people. So that's where there's been this misconception of people talking about, let's do herd immunity through the natural way with COVID-19. Well, it's not just letting everyone get sick and immune. That is not, we would have, tremendous illness, death, suffering that would result from that. So why do we need herd immunity? Vaccines are very effective, but they're not 100% perfect. And there are people with legitimate reasons, like those with compromised immune systems, those on chemotherapy, that might not be able to be vaccinated, babies who are too young to receive some vaccinations before, the recommended vaccination times, or the elderly and those with weakened or compromised immune systems, again, can be at increased risk for vaccine preventable diseases. In our global situation now, the thing is, diseases that used to be, on the other side of the world are now just a plane ride away. And, we've seen this with COVID-19. In some countries, including countries of Europe, outbreaks of vaccine preventable diseases still occur regularly. In Texas, we've got pockets of unvaccinated communities that have increased the risk of a vaccine preventable disease outbreak. This was from, just remember a year or two ago, these measles cases, there was the cases associated with Disneyland. In 2019, we had 1,203 individual cases of measles that were confirmed in 30 states. That was the greatest number of cases of measles reported in the US since 1992, and since measles was declared eliminated in 2000. Now, as I mentioned, the impact and the public health success story of immunizations, it's estimated for each birth cohort, each group of people that's vaccinated with the routine immunization schedules, that saves 33,000 lives, prevents 14 million cases of disease, reduces direct healthcare costs by $9.9 billion, and saves $33.4 billion in indirect costs. But despite the progress, we still have about 42,000 adults and 300 children in the United States that die each year from vaccine preventable diseases. And as I mentioned, there's these communities with pockets of unvaccinated and undervaccinated populations, and these are causing increased risk. And these are the number of non-medical exemptions in Texas from 2003 to 2017. You can see it's been increasing every year, the number of kids that get these non-medical exemptions. Just point, vaccines don't cause autism. That was disputed. I mean, it was inaccurately linked to autism. It was actually a guy who I think he still lives in Austin. It was the Lancet, but the study was, they showed that the data was falsified. They couldn't be replicated. The researcher lost his license to practice medicine. The journal retracted the study, and there have been many high-quality research studies subsequently that showed no link between vaccines and autism. But it's still out there. It's out there in social media, and so it's hard to fight that misinformation. But as in summary, immunizations in general are one of the 10 greatest public health achievements of the 20th century, one of the most cost-effective public health interventions. For each dollar invested in the childhood immunization program, there's $10 of societal savings, $3 of medical savings. This past 20 years of childhood immunizations prevented over 300 million illnesses, 732,000 deaths, and $1.4 trillion in cost savings. And then I love this quote from Anne Schuchat from CDC, that we are the victims of our own success. Because of our success, fewer and fewer doctors, nurses, and parents have witnessed the serious and sometimes life-threatening consequences of these diseases. Because of our success, parents may wonder if vaccines are necessary, and they may worry that the risk or temporary discomfort of vaccinating may outweigh the benefits of protecting their families from vaccine preventable diseases. And exactly, I mean, so many of us, we've never seen those iron lungs or seen kids with measles or these vaccine preventable illnesses. And so we are a victim of our own success. Now I want to move into just some of the COVID-19 vaccine issues, and I'll just go through briefly the stages of vaccine development, and particularly how it's applying to COVID-19. First, and there's a preclinical stage where they try to determine how will this vaccine work. And they, so with a lot of researchers trying to design or find natural or synthetic antigens. These are the foreign substances that or in your body induce an immune response from your body, and trying to trigger the same reaction that a real live virus or bacteria would cause, and then identifying that right antigen or antigens. Usually it can take up to 4 years to identify for that preclinical stage of vaccine development. Then there's the phases 1, 2A, and 2B, and these are to determine, is it safe? And what is the right dose for a vaccine? Phase 1 testing, this is the first time then the vaccine's tested in a small group of adults, usually about 20 to 80 people. It's to evaluate its safety, measure the immune response it generates. The phase 2A studies aim to determine the most effective dose and expand the safety experience with the vaccine. The researchers look for expected reactions to vaccine, the things that might be expected, like headache, muscle pain, redness, swelling at the injection site, low-grade fever, but also looking for serious adverse events, which would be expected to be rare, but and they have to look at this over the entire duration of the study. You've seen some of these in the news, some of the clinical trials that have been paused because of some adverse reactions that have been identified. Then the phase 1 and 2A clinical trials normally last several months to even a year before proceeding to phase 2B or phase 3 trials, in which then the pool of people receiving the vaccine increases. The phase 3 trial is how effective is the vaccine. In this stage of the clinical trial, even more volunteers receive the vaccine to study whether it's effective. I think there are right now 4 large-scale trials of the COVID-19 vaccine that are underway. Last month, one just began. I think they began considering an investigational COVID vaccine to tens of thousands of healthy people, as well as of those particularly vulnerable to COVID-19. They were looking to recruit people in areas where the highest rates of viral transmission are. So in preparation for this, they worked with epidemiologists, modelers to try to predict some of the hot spots. Before the volunteers are vaccinated, they're tested, make sure they don't have the COVID-19, the SARS-CoV-2 virus. Half of the group is assigned to receive the vaccine, other half receives a placebo. Then they're all followed closely for up to 2 years to see if they develop COVID-19 related symptoms. And then they can, again, these phase 3 trials can sometimes take years. Current plans, as you've been hearing, are to get results much sooner, in a year or less. and creating as large a trial as possible with up to, I think this one they're trying to get up to 60,000 people. Then, the regulatory approval process and licensure, is to assess, is it ready for, distribution and use in the world? After a successful phase 3 trial, the vaccine manufacturers submit the application to regulatory bodies in the US. It's the FDA. At this stage, they review the clinical data to make sure the vaccine is safe and effective. For FDA approval, among the things that have to be shown is the manufacturing process is consistent, that they can produce consecutive batches of the vaccine that induces the same immunity in people. And once it's approved, then enough of the product needs to be manufactured to immunize those who need it. And then phase 4 of this, even after it's in production and out there, you still need to keep monitoring and make sure it's still safe down the road. And so, even after it's licensed, the regulatory agents stay involved. They continue to monitor the production, inspect the manufacturing facilities, test the vaccines for potency, safety, and purity. And they also monitor adverse events that could occur to receive the vaccine. They have the vaccine adverse event reporting system. And then, there's a phase 4 clinical trials, optional studies that the pharmaceutical companies can do or be required to do after vaccines licensed to continue to monitor safety and effectiveness. With COVID-19, because of the concerns about the politicization of it, the announcements that, hey, we're going to get something before conveniently November 3rd, there was the 9 drug companies that are currently working on this pledged to stand with science on coronavirus vaccines. A joint statement by these competitors was seen as an effort to restore public trust, as President Trump's push for this vaccine before the election. The 9 pharmaceutical companies issued a joint pledge. They said they'd stand with science and not put forward a vaccine until it had been thoroughly vetted for safety and efficacy. They did not rule out seeking an EUA, or emergency use authorization of their vaccines, but they promised that any potential coronavirus vaccine would be decided based on large, high-quality clinical trials, that the companies would follow guidance from regulatory agencies like the FDA. And quote, they believe this pledge will ensure public confidence in the rigorous scientific and regulatory process by which COVID-19 vaccines are evaluated and may ultimately be approved, they said. So, some of the equity considerations, I know they're going to be discussed now. There many thousands of volunteers are actually needed from minority groups for these huge clinical trials that are underway and are about to begin. The scientists say it requires a diverse group of test subjects so that we can determine whether vaccines safe and effective for everyone, and to also, provide broad public confidence in the shots as they become available. There's expanded outreach now by some of the vaccine researchers and health officials they're actually getting a late start, unfortunately, for the communities. There's a history of scientific exploitation and racism. I'm sure that it will be discussed as we proceed with this, that, many in these groups are reluctant to roll up their sleeves and participate, and justifiably so. One of the other manufacturers, pharmaceutical companies, Moderna, as they neared its goal of 30,000 study participants, some sites slowed recruitment to try to increase minority enrollment. They're now at about 28%. Pfizer recently asked the FDA to expand their number of volunteers. They said a quarter of the US participants are from communities of color. If you count the sites in Brazil and Argentina, it's more than that, and so they are trying to recruit more Hispanic population persons. It's very important the vaccine works for everyone. If it doesn't, we need to understand why. One of the researchers at the University of Miami said, researchers need to be able to compare the different vaccines, see how one might better fit a population than another. And a lack of diversity in research would have a ripple effect once any vaccines approved for widespread use. Even before final testing would be begun, a poll from AP found just 25% of African Americans, 37% of Hispanics would get a vaccine once it's available, compared with 56% of whites. Just if and when we have a vaccine ready, if you didn't have enrollment in minorities, then people are going to say, why should I put the vaccine in myself? And too often, how can you possibly expect me to be a big guinea pig when time and again we've been volunteered on a community members and not seeing the benefits of the research. And so again, researchers are still trying to recruit more volunteers over the next months. And NIH recently began a program to better inform minority populations about the vaccine studies and other COVID-19 information. And they awarded $12 million to try to get help in the form of community engagement teams in 11 especially hard-hit states. So I think that's all I've got. I'm happy to answer questions or wait till the end. And again, was just trying to set the stage for the rest of the discussion.
Well, Dr. Wong, we do have one question. How does COVID-19's ability to mutate affect the vaccine's development process?
You know, I mean, I think there's a lot that we still don't know about all of this. You know, they're trying to, you know, determine that in the research and the efficacy studies that they're doing with the vaccine. You know, is it going to be like something like the flu vaccine where you have to get it every year? Or is it going to be something that it has long-term, you know, effect? And we don't know these things. So that's why these are all very early stage. And this is, you know, really record time in terms of getting you know, these products through some of these processes. But we don't know really.
Okay, thank you very much, Dr. Wong. That does set the stage for the coming discussions right now. And this time I'd like to introduce Director Stephanie Hayden. And she is a licensed master social worker, and she's director of the Austin Public Health Department. She's responsible for management of department operations, including fiscal management of a $143 million budget. She has been employed by the city for 19 years, and during this time, she's held several positions with progressive responsibilities from supervisor, manager, assistant director, and deputy director. She has spent most of her career as a public servant, working in the field of social services, and 26 of those years have been in management. Prior to working for the city, she worked as the director of clinical services at the Alternative Learning Center with Austin Independent School District, and she was with the assistant director of the Williamson County Mental Health Center. She has a Bachelor of Arts in Social Work from Prairie View A&M University and a Master's in Social Work from Our Lady of the Lake University's Wharton School of Social Services. She is a graduate of the City of Austin's Executive Academy and Leadership Austin's Essential Class. She is certified as a Youth Program Quality Assessor and Youth Work Management Training Consultant, and she is trained in results-based accountability. At this time, I would like to turn this over to Director Hayden so that we can hear from you and your work, hear about your work. I apologize for my phone ringing. Okay.
Okay, I understand. Okay, I'm going to go ahead and share my screen. Okay, here we go. Okay. Thank you for the opportunity to present this evening. I want to spend some time talking about how we need to utilize health equity and community engagement during this COVID-19 response. I will, this is a little overview of my presentation. I want to provide a little bit of information about what does Austin look like from a health perspective, and then move into the public health response, which is this COVID pandemic we're in the middle of. I'm going to spend a little time talking about our social services branch. I'm going to share some information with you from our dashboard. I am going to share our most recent information about our flu campaign and what's happening on the flu scene as of now. and spend a little time with the COVID vaccine, and then kind of wrap up with health equity and community engagement. So when we think about Austin, Austin is just on so many lists. Most people would like to retire here. It is a place for young people to be. It is a technology city and county. And so most folks are really eager to live in Austin. And, you know, when we think about just kind of how the community looks in general, you know, overall we're a healthy community. We are typically, you know, we kind of fall between, you know, last few years, we fallen between about 7 to 9 over the last 3 or 4 years as far as Travis County with the health rankings across the state of Texas. You know, we have a diverse city, very highly educated, with folks that have high school education all the way to secondary degrees. About 50% of the people here in Austin have a college education or secondary degree. However, significant disparities exist. You know, when we, you know, look at, there are concentrations of poverty throughout the community. And you may be in meetings where you hear individuals talk about the Eastern Crescent. And so that is East Travis County. So if you think about, I'm going to kind of take you on a pan from South Austin to North Austin. But initially, you know, thinking about the 78744 Dove Springs community, swinging over to Del Valley 617 area, and then coming through East Austin 02, continuing further up the Colony Park area, the 24 area. But we also hit that 25 area. We swing out to Manor and kind of swing back in and head up to Pflugerville. And so within those pockets, that is what is called the Eastern Crescent. And those are the areas where you may see more poverty, a lack of education, more folks that are uninsured, and a greater concentration of Hispanic and African Americans. I will also say that even outside of those areas, there are some other pockets in Austin, like the Rumberg community and the St. John's community. And so those are some other areas where we've noted that some of these disparities exist as well. Most of you have probably heard the terminology of the social determinants of health. You know, these are basically influences of health. It's where you live, work, grow, play, and worship. There's been studies that have been done in Austin that really just show that, you know, if you use Interstate 35 as a dividing line, individuals that are on the west side of 35 may have a longer life expectancy than individuals that are living on the other side of 35. Well, as time has moved along, we still see in the 02 area, even as East Austin is gentrifying, we still have pockets in the community where the lifespan is less. But now we're starting to see maybe the 183 may potentially be where your greater disparities are existing on the, you know, to the east side of 183. And so we know that these things really contribute to determine your health outcomes. Now, with our COVID-19, the department started working on this COVID response in February. we initially started receiving information from CDC and the State Department of Health Services that we needed to mobilize. And so we did. We mobilized our Department Operations Center, which is in the Public Health Department. And so within that arrangement, we began to monitor individuals that were returning from Wuhan, China. And so we started to work very closely with the CDC in order to do that. In March, as we, I know most of you may have heard about the process where the department initially declared an emergency early March. And we declared an emergency prior to having a case. And so the reason we did that is because we realized that as a city and a county, we needed to put some additional efforts in mind and set up our additional strategies within the city and the county. So we, the Mayor Adler and at the time Judge 𝐓𝐻𝐡𝐸 both declared an emergency. And so shortly after that, we canceled the South by Southwest event, which was very significant. And shortly after that, we received our first case. During this entire time, our epidemiologists and our surveillance have continued to do case investigations and really tracking the positive cases within Travis County. We've partnered with healthcare providers. We have a couple of agreements with UT Dale Medical Center, as well as community care. And those individuals, UT Dale Medical School, shall I say, they are actually, initially, they were more of a partner to help us with the University of Texas, and they are continuing to do that. And then community care is the leader over the indigent care clinics. And so they are working and doing the contact tracing and case investigation for their clients. And so we implemented a testing platform. Our system is called Austin Health Force. And so it is a testing platform where you go online and you can schedule an appointment at any of our drive-through or walk-up sites, or you can request to have a test taken at home. And if you don't have access to the internet, we put in place where you can call our nursing line, which is our medical line, and we will schedule you for an appointment. One of the things that is so important when you are thinking about the branches that are essential to a response. The social service branch has always been a branch that we have stood up during all of our responses. You know, going back to when I worked the Katrina response, we set up a social services branch. As you may think about it, folks are coming here from New Orleans, and a lot of people, you know, basically started over. And so over the years, we've made some changes. And one of the key changes that we have implemented is that we lead with an equity lens. And so that is our North Star. And so when we think about setting up systems, then we really need to think about, you know, if we're putting something on a website, and that is the way that individuals can access our services, for the people that don't have a computer or that don't have access to the internet, we need to put in place another way for individuals to receive that assistance. And so throughout this response, we have used this equity as our North Star as we're providing services. So with our food access, our community services, but we also needed to identify some priority populations. And so, you know, as we built up our priority populations, we started working with individuals, service organizations that provide services to these populations. So for example, we knew that as we started to move through this process, there's been an increase in domestic violence. And so it was important for us to work with our key social service agencies that are providing those services and how we can be supportive to them in their efforts. The things that have been really important for us, as I said, have been a partnership. Internally to the city, we looked at how we can do outreach efforts, and some of them we wanted to make sure from a, you know, to be really safe, how could we do some things virtually? But we also know we needed to actually get flyers to in the hands of actual clients. So we mailed things to individuals. We kept core services open, and so we put flyers in those bags, and we actually had folks that made phone calls. And so when you're really thinking about providing the most effective services, you have to meet people where they are. And you have to think about, you know, what is the best way for me to ensure that I'm getting this information to individuals. You know, we've set up strike teams, like with now, as you're gonna see with the data, we have race, ethnicity. You'll see that with African Americans and Hispanic and Latinx folks, they're disproportionately represented. And so how do we be very intentional? And, you know, we've used television, we've used radio to really get that information there. And we have also gone to those radio stations to be a part of those interviews so we can get that information out to the community. But that partnership is essential. And those partnerships with individuals that are, you know, very well known in target communities has really helped us to be very successful. So as you can see here, this is just showing you our positivity rate. And so, you know, basically what we have a dashboard, and the dashboard will show you our positivity rate. And, you know, we're doing overall, we're doing pretty well. We've roughly been about 4%. We have over 30,000 cases. We had 98 new cases today. Unfortunately, we have 442 individuals that have died because of COVID complications. And so as a community, you know, we continue to move along the pace because we're working with schools and other industries are opening. So we have to continue to watch the data and see what the science tells us. As you can see here, these are the hospitalizations. This is another one of our performance indicators. And as you can see, our Hispanic and Latinx population has really, was really increased and it's gone up. It's come down a little and then it's kind of peaked back up. And so that's why it's really important for us with our, we have a Latinx strike team, and we meet and we have developed mitigation plans. And one of the things that we noticed is that with some of the target zip codes, we put our testing sites in the zip codes where we have more positivity rate. But we've also partnered with some grassroots organizations to really be able to do targeted outreach and get the information out to them about, this is the testing site. This is where we've had financial assistance in our community. We have rental assistance, and then we have, right now we have an at-risk workers program where individuals can call our hotline and schedule an appointment with one of the nonprofit partners. And if the individual has taken their test, they're waiting for the results to come back, and they're not going to be paid, our staff are able to work with this partner, and the partner will educate them about the Families First Coronas Act and talk to them about how they could be paid. And if that employer does not offer that as a benefit, then our team will work with that nonprofit and determine what that person would miss for 14 days of work, and then provide that funding to them. So we're really excited about that. Right now, as a community, we're at stage 3. We have been at stage 3 for quite a while. We have really kind of looked at stage 2, but to be honest with you, our hospitalization rates have dipped down over the last 3 months to under 10. But we keep kind of bouncing back and forth. And so because we have been bouncing back and forth, we're still in the stage 3 because of the hospitalization rates. This is flu season. Who needs a flu shot? That would be you. My hope is that if you have not already gotten your flu shot, that you will definitely get your flu shot. One of the things that's really important is that when we think about the flu vaccine, the department does have shots for tots and Big Shot Tots Clinic, and those are for individuals that are uninsured or Medicaid recipients, or for uninsured adults. However, if an individual has insurance, you can use this vaccinefinder.org, and it will find a location for you with flu shots that's near, like your home or a place of where you work, or if you're volunteering, and make it convenient. We do have 2 flu clinics that we are going to provide for individuals that are uninsured or underinsured, October 24th and November 7th. What we're going to do with these 2 areas is that we are going to be providing flu shots, but we are going to use them and basically do a drill to basically simulate an activity for us when we have the vaccine available. So we'd be able to kind of do some lessons learned from these 2 events, looking at a large crowd, as you can understand, the expo center. And so our hope is we'll be able to draw in a significant amount of folks. And back in 2009, when we had H1N1, we used that same process as well. So when we would be looking to set up what we call point of distribution sites, we would use something similar to what we're going to do on the 24th and the 7th, coming soon. This is just giving you a snapshot of where we are with the 2 positive influenza tests that we've had, and the type of the strand that they had. This is similar to what you just noticed from Dr. Wong's presentation. This is just the promise that the big pharma's leaders pledged, that they are really doing this because they wanted to make sure that the community really trusts them, and really put us in a place where because there are these executives came together and they made this pledge. And so they are committed to this pledge, and they are committed to the efficacy of the vaccine, and they want to make sure this is not no political affiliation, but really just wanting folks to know that they're going to do everything they can to be able to get once the vaccine is ready, then they will start to supply that to our communities. What we also know about the vaccine is that the state of Texas has also developed and are moving along with what they're calling Operation Warp Speed. And so this program is the federal program where the state of Texas has reached out to all of the health directors and departments across the state of Texas and have put in place a timeline. They are anticipating, and this is subject to change, and so they just remind us as we are talking about this to the public and our elected officials, et cetera, that since this may change, their target plan is that in November and December would be months where vaccine would be available for first responders and healthcare providers. And then in January, from January through July would be the time frame when as all communities will begin to see more vaccine available. And so as a result of that, the city of Austin has put together a vaccine distribution coalition. And this is, Austin and Travis County. And so what we know is that because of things that have happened in the past with, for example, the Tuskegee experiment, which was the public health federal government that actually did that experiment, there is mistrust in the community. And so because we know that there is mistrust in the community, we feel like it's going to be important for us to make sure that we are using equity again as our North Star. And so we are meeting with several key partners, and within that number of folks who we're meeting with, they're also advocates as well, because we want to be able to understand, once there is an approved vaccine that is safe for our community, how can we roll this out to communities that need it the most, and be able to provide that additional support to them. And so this vaccine distribution coalition is going to be able to provide us information. So we're going to be developing plans and strategies. We're going to identify priority populations. We're going to look at our messaging and additional community engagement. As I said earlier, we put in place some ambassadors. And so we have zip codes with the highest positivity rate. And so within those zip codes, we have nonprofit programs, which grassroots programs that are very well known in those communities. And so what we've done is that they have been able to, we partnered with them to pass out face coverings as well as hand sanitizer, information about our testing, but those are trusted sources in our community. So we are going to be really listening to them more as we've done more and more over the last 6 months. We've done more of that. And so that brings me to the health equity community engagement. The voice of the community is required and will lead to success. We know that as we are moving forward, We're going to have to think about non-traditional settings. We do have, as a part of our social services branch, we have a faith-based arm that is working with our churches. You know, we have to look at, you know, apartment complexes that may allow us to come in. We've got to look at the hours that, you know, we are offering, the services that we are going to do. You know, whether it's the continuing with the testing that we've done, and when the vaccine is available. And we have to make sure we have culturally and appropriate materials. And so all of these things are going to be important. They will be our North Star, but we know that working side by side with trusted individuals, we will be able to be successful in this space. The city of Boston is committed to making sure that once the vaccines go through their trusted process that has been put in place and it has moved through all of the authorizations, we will work closely with the community to engage and to provide the vaccine. So that completes my presentations, and I am available for questions. Thank you.
I have a question. I typed it in. And my question has to do with the League of Women Voters, which has been growing by leaps and bounds in the past 4 years. And our members really like to be engaged and in advocacy and education and whatever kind of work that is available that helps in areas pertaining to equity. What sort of possibilities do you see that League members might get involved with advocacy and education in this area?
Well, I tell you, we are always excited when we have groups that are willing to step forward into, you know, to help us with education and advocacy. What we have typically done is that, you know, when we have groups, and if they are willing to, you know, maybe have, you know, like a chair or a spot to attend some of our branch meetings, we will definitely invite them to that. When we have information that we know we need to get out to the public, it's always great to reach out to a partner and say, you know, here is some additional information. There's also, as we look to kind of looking at our pods, you know, there may be ways for folks to volunteer if they would like to volunteer. But there's so many ways that we can actually plug in individuals that are willing to help us to either one, virtually get the word out, and you know, and reach others that way, and or just be a part of some of our conversations with our team. A lot of the task force are not folks that work for Austin Public Health. They are either with a nonprofit group, you know, or they're external to the city. That is really contributing to our success. So we definitely welcome that.
There's a question in the chat box.
Okay.
And it's directed to any either Director Hayden or Dr. Wong. What determines when a vaccine becomes mandatory for school, college admission requirements? Excuse me, city or state level decision or federal?
Well, I know I'll take I can talk about that, and I know Dr. Wong may want to kind of chime in. So, you know, as a state of Texas, the Department of State Health Services will determine what vaccines are mandatory. And we have I'm gonna try to not be so technical, but we have a list of notifiable conditions. And if there is a vaccine that comes along that is recommended, that we know, it's kind of like polio, you know, they would recommend that at the state level. Even at the state level, as that is put into place, you know, there are some, you know, mandatory vaccines, and then there are some recommended vaccines. And so they typically put them in, you know, in that category. I will also say it depends on where you work, because some places, as a condition of employment, may have a policy in place that requires you to get a certain series of vaccines because of the work you do. And that could be a condition of employment. We have some key positions in Austin Public Health that we require certain vaccines of them, for those employees to have. Last year, we recommended the flu to be, we recommended flu as a vaccine. This year, we implemented, it is a requirement for them to add flu vaccine to that list. And so, you know, whether you get it on the job, going to our wellness sites, or outside using your insurance, you have to bring that proof back in, and then we track that. And so some places will have that as a condition of employment.
Thank you very much.
That,
Oh, is there another question? Sorry,
yeah,
Mary.
there are several actually. So for Dr. Wong, I think this person writes, an article came out talking about the live vaccine nasal spray being better to protect against both flu and COVID. Is there any push to switch to the live vaccine for vulnerable populations? And this is, she just read one article and she's just wondering, she said there's a large amount of conjecture and not much fact in the article, and just wanted you to address that.
Sure. Yeah, I've not, you know, for the flu vaccine, there has been a live nasal vaccine that a couple years ago was actually pulled because of it was not as efficacious. I think last year it did get reinstated as an option. In terms of the COVID vaccine, you know, they're all still in the clinical trials. So there's really not, that's not an option that's being discussed as in the initial rollouts at this time.
All right, and this is another question. When you're talking about phase 4 of the vaccines with Operation Warp Speed, are Austin Public Health and other public health departments also going to monitor the known side effects in the community, or is that only the responsibility of the manufacturer? It might make the community feel better to know that someone local is also going to be monitoring post-vaccine.
Yes. So during our training, that was a part of our training, that if there are any adverse effects with individuals getting the vaccine for COVID, we have to know what those are and provide those to the state of Texas. And typically what, you know, at the local level, what individuals submit to the state of Texas, we also keep, you know, so we have an idea, and if we're, you know, needing to run reports, et cetera, for, you know, any of our elected officials to give that aggregate data, we will have it available. So we definitely do that. I see that there's been discussion about a rapid test not being part of the data set.
Yeah.
I will tell you with the rapid antigen test, that is a probable for Austin. And PCR is like the gold standard of tests, which is kind of your nasal swab that's used. However, one of the things that we are going to do, we are going to make a change to our dashboard because we are seeing more antigen tests being provided. And so we're going to make a change to our dashboard and have the probable cases for the number of folks that have come back testing positive with the antigen test.
That's all the questions that we have in the chat box now.
Okay, thank you very much. I think we've got a good overview from Director Hayden about how Austin Public Health is overseeing these the role of reaching out to the community and providing information. And I hope that the league will get involved in supporting all of that work. I would like now to introduce Dr. Jericho Thomas Hockaday. She is a licensed surgical assistant and Dean of Specialty Programs in Central Texas Health Institute. She was born in Baytown, Texas, and received a Bachelor of Applied Arts and Sciences from Texas State University at San Marcos, and master's and doctorate degrees from Capella University. She's had a 21-year career, her 20-year career in healthcare, and has worked as an emergency room technician, a surgical technologist, and a surgical assistant in various hospitals in the Austin area. In 2011, she accepted a position as surgical technology instructor at the newly opened Brown Mackie College, San Antonio, and served as an instructor, clinical coordinator, and acting department chair. In 2015, she completed an advanced certificate in surgical assisting from Meridian Institute of Surgical Assisting in Nashville, Tennessee, and was then invited to become a partner and managing director at River City Assisting LLC Surgical Assisting Group, where she managed 6 employees. This group provided surgical assisting services for 15 surgeons in Austin in the areas of general orthopedics, OBGYN, plastics, ENT, and brain spine surgery. She is now co-founder of the Central Texas Allied Health Institute, which is a new institution of higher learning that seeks to bring allied healthcare training to individuals in vulnerable communities who have not historically had access to these types of training programs. She lives in rural South Travis County with her husband of 10 years, William Ben Hockaday, and their 16-month-old son, Carter Thomas, and their dog, Chula. Servant leadership and public service is a family legacy for Dr. Hockaday and her husband as well, who is a career federal employee at the Veterans Administration. And we're very happy to have you here this evening, Dr. Thomas Hockaday, and hear some more about your new school and all of the things that you've been working on in the context of that school.
Hi, good evening, everyone. My name is Dr. Jericho Thomas Hockaday, and I thank you for that wonderful introduction. I'm happy to be here to provide. I had all these great things to talk about, and Director Hayden and Dr. Wong took them all away from me. So I think that the best way for me to fill the space is to talk about the role of nonprofits in the community, as Director Hayden discussed. Those trusted relationships as far as helping us get past this COVID get it out the door and get it on its way, because I know we're all tired of it. So I think I've said this before, is I feel like I sit in a very unique situation as we look at this pandemic, because I am both a woman of color in a community that's been marginalized historically, but also a healthcare professional. So I try to use my space to bridge that gap between the members of the community who, for good reason, as Dr. Wong said, may not be necessarily ready to trust our medical community because of so many decades and probably centuries of exploitation, medical exploitation. But I know as a medical professional that it is essential for us to be able to get to those communities. You know, there's a long history around vaccination, and we've discussed that, so I won't go back over that. But oftentimes, communities of color are usually the last ones to be serviced in these type of situations. They'll be often used for the trials, but when it is time for the successful vaccinations to come out and be distributed, they often are the last folks to receive the vaccinations. I think Dr. Wong spoke earlier about how the drug companies got a late start on the communities, reaching out to the communities of color to be able to participate in the vaccine trials. Well, for me, I feel like as a medical professional, that is problematic in and of itself, because from the very beginning of this pandemic, we have seen that communities of color are the very first folks that were affected by this and have continued to be disproportionately affected by it. So the fact that we as a medical community are just now beginning to recognize that we need to include folks of color in these clinical trials says that we still have a lot of work to do. The second thing I would think about in that space is we as healthcare professionals of color need to be more vocal about saying these things, because I'm not sure that we've always been most willing to speak as loudly as we could or should, for good reason, because there's so few of us in these communities. And just quite frankly, we're afraid of speaking out too loud and endangering our status or our employment or whatever the case may be. But I think that COVID has absolutely given us the focus of, if we don't speak out for our communities, especially as healthcare workers, nobody will. So in late March, early April, I was able to sit down with Director Hayden and talk to her about this, and we really had a good conversation about this. At the same time, I was invited to join the Community Resilience Trust as a subject matter expert, and very immediately I was trying to be the subject matter expert and just do what I needed to do, but very early on, they pushed me out into the forefront and said, you need to talk about this. We don't have anybody that's talking about this right now. So as we saw the positivity rates as a group, as the Community Resilience Trust saw the positivity rates going up, we decided that we wanted to, and after my conversations with Director Hayden, we decided that we wanted to be a part of this fight. And our staff at the school and our members of the Community Resilience Trust said, let's do something for our folks in our community. So in partnership with CRT and with the Austin Area Urban League, we went on a several months proposal and back and forth and logistics about standing up a COVID clinic, testing clinic in East Austin to help with all of the wraparound services around the testing that Director Hayden discussed. So in August, we were able to get the funding we needed. Director Hayden really helped us with advocating for this. Several of the council members, Councilmember Harper Madison, Commissioner Trevelyan, Councilmember Rudy Mateer up in Pflugerville, really helped me to get the word out about what we were wanting to do in the Community Resilience Trust. And we opened the clinic the beginning of September, and we've had about 300 people so far, and we're getting our footing, but we're seeing an increase, especially in the last week. We've seen a significant increase in, as a medical professional, I probably understand that that's probably around the flu or cold season getting ready to start. Not folks with COVID, but people just wanting to come get tested and know their status. Because I think there's an awareness out there. We also have several partners around the clinic. The Urban League is there, Austin Area Urban League is there, working with folks who are essential workers, particularly essential workers of color, to help assist them, as Director Hayden said, about getting them services while they're in quarantine. I mean, many of these folks still have homes and apartments and bills and children that they have to take care of while they're out of work and quarantining. So we've had a lot of success with that. The students are, as I said at the beginning, the students are getting a really great education in how to handle patient care and the testing and that type of thing. We have a partner who we're working with around getting some food access, and we do PPE kits. We hand everybody a PPE kit as they leave. And the great thing about it is the Community Resilience Trust has helped us develop some infographics, because Dr. Hockaday is not good at infographics. And we put some infographics together with our medical team at the school, and we've done a lot of printing and handing out packets to folks as they leave that's inside their PPE bag, to show them how to clean their home, how to keep sanitized, washing their hands, and caring for folks at home, children, elderly, all types of folks that they may be living with or in close contact with. I certainly understand how that is. I have one immunocompromised person and an elderly mother that I have to make sure that they are doing what they need to do to keep themselves safe. And for many people of color, this is a reality. We don't necessarily have the resources that other communities might have. So especially for a person like me, who's a person in the community and also a healthcare professional, my phone rings all the time asking for advice on how to deal with things. So we really wanted to think through all of the things that we could possibly address. We can't address everything, but for many of the folks that will come to the clinic, these are folks who may not have access to healthcare, and this may be the only time that they come in contact with a healthcare professional, and honestly, someone who can provide them with social service needs and wraparound services. So we wanted to make sure that while we have them there for testing, we also address some of those social determinants that Director Hayden was discussing. We have a fantastic supervisor out at the clinic. Her name is Diane, and she was in charge of an infectious disease clinic in the military in Korea. She has done a fantastic job at the clinic. We have basically gotten our lead time down from start to finish for a test and social services to between 5 and 6 minutes. So it doesn't take long for the folks to come through, and we try to be equitable as possible in getting information and making sure that anybody that can get the help that they need can get it. We've reached out to several community organizations. We've really been helpful. The Austin Area Urban League has really been helpful with us in getting that out. We are going to start next week. We've had some conversations with Cap Metro. We're going to start next week putting some information on the buses about the clinic. We had a conference call with parents at Texas Empowerment Academy last night to talk to them about the services that we're providing at the clinic. And we are strategically placed on Airport Boulevard between Martin Luther King and 12th Street. So the traffic that we get all day, every day, and we have signs and everything everywhere to make sure that folks see us and know that we are there. We also encourage, we've been on 𝐾AZI, we're doing some work with several radio stations in town, and we're not only encouraging the testing and the contact tracing, but we're also encouraging our folks to come and be a part of this, and people who are out of work and are interested in being a healthcare professional and seeing how they can help their community, we encourage them to come and enroll. Folks who are laid off or have been unemployed or underemployed during COVID, I would be remiss to say is we don't use this, we use it as an opportunity to do a little marketing for ourselves and the good work that we're doing in the community. So, and we've had a wonderful response to it. We have so many folks of color, Latinx, AAPI, African American folks coming in saying, you know, we want to do something to help our community. And if this is the way we can do it, this is what we want to do. Because what this does is not only increase the knowledge and the base of testing in the communities of color, but it also helps us to create more equity in our space here in Austin for the health professions. Because I moved here many years ago, I'll say many years ago, to go to college down in San Marcos, as she said at the beginning of the presentation. And there were probably less than 10 African Americans I knew that were working in both hospital systems. There was only 2 at that time. And unfortunately, I haven't seen, I've seen a little growth, but not a whole lot. And I think that needs to change. We have data set after data set after data set that says that folks of color get absolutely better results and better care from providers who look like them, who are trusted in their neighborhood, who give them good advice based on cultural competence, who speak to them in a manner that is culturally competent as they come in for their visits. And we want to make sure that we continue to grow that. And I want to encourage that because it provides us with a better wealth of knowledge around our communities of color, and provides Director Hayden with a better understanding of how those communities are working when we have a broader scope and of healthcare providers of color in the community. So I think those are the things that we are most proud of right now, is being able to provide that service to the community while also being able to help folks get tested and know their status and get them social services that they would need. We hope that once the vaccine is out and open, we can continue to participate as a vaccination clinic. Our students are very excited about what they're doing now, and I'm sure they will continue to be excited as we go along, because we feel like this is a thing that we are called for, to make sure that we are providing a service for our community and continue to be that service for our community going forward. It's so critical. I cannot stress how critical those public-private partnerships are, particularly in communities of color, because I mean, I've had conversations with my mother, who's 75 years old and living 200 miles away from me, and she won't go anywhere and talk to any medical professional until I say, yes, that's okay, go ahead and do it. So getting that word out and getting those trusted partners will go a long way. I mean, we have a lot of work to do with building that trust back between healthcare providers and communities of color. But just because it's hard, I always tell the students, just because something is hard doesn't mean you can't do it. So I want to make sure that we hear so much negativity around how this has been executed, how it has been played out on a national stage. But I think that this is the opportunity for us as a community, as a state, as a country, to look at what we are doing and say, let's take this moment in time to look at this on a realistic scale and take those resources and change how we have been doing things, because it needs to be. We are at a level of critical mass here for our communities of color all across our nation. And we hope that as we go forward and present this model, that we can be a model for the nation and people can say, hey, look what they did. At the beginning, I said we're the little school that could. We hope that we can be the little partnership that could and be a model for the nation to show that this is what can happen when you work together, you work in tandem. And additionally, for our local governments, our state governments, to place folks of color in leadership positions, in our health departments, in our social services departments, who understand that cultural competency. My conversations with Director Hayden are fairly simple because we both understand what's happening and what needs to happen. I'm not sure that I could have had such an easy, smooth conversation from someone who did not understand the needs of the community. So we need to uplift those public-private partnerships, but we also need to uplift those folks of color who are working in our governmental, federal, state spaces, who are trying to make sure that our public health is equitable and culturally competent. So I think that's, I'm not as, I don't have as much prepared as everyone else, because I wanted to speak to that space. And I think we've covered a lot of what needed to be said tonight. So if there's questions, I'm happy to take questions.
Yeah, there are a couple of questions. How are clinic providers approaching clients to make them feel safe when they come for testing or other help? And
at our clinic?
Yeah.
So everyone who is a provider, whether they're a student intern or one of our supervising instructors, is a person of color. That is how we feel the best, that's what we feel the best way to make folks as comfortable as possible. They walk in, they are greeted by a person of color at the front door. They're passed on to do the pre-registration or to walk in by a person of color. When they talk to the Austin Area Urban League, that's a person of color. I mean, the gentleman who is our escort, that escort them from the front door back to the testing area, is a gentleman of color. The ladies that work, we typically call it the hot zone, and that's a horrible phrase to say, but that's what we call it in the industry. When they're coming back, every person that's back there that's testing in the area are all persons of color. So they will see someone that looks like them over and over and over through the entire process.
What kind of steps are you taking to shelter them from COVID?
Our students? Okay.
The people who come to the clinic.
So we 100% use the principles of aseptic technique and universal precautions. And I used to work in surgery, so my idea of universal precautions and sterile technique in our clinic is probably a little bit more than some of the other places, but I am very concerned about our students, our workers, and the folks that are there. I know we've had some discussions. Some of the staff from the city come out and say, my goodness, y'all are doing way more than the other sites are doing. But I think that was around my need to want to replicate what I've been accustomed to my entire career. So once they've come through, they should feel very safe in our facility and in our testing site, to know that they're being handled and their test is being handled in a very specific, sterile way to ensure not being contaminated, to ensure that they're not exposed. And very honestly, I care a lot about our staff not getting it either. So we utilize them at that site only. We don't introduce them back into our campus, none of those things. They are at the testing site, and the students that are working at the site are receiving all their didactic work from home. So they are 100% isolated to the clinic and to their home, so as not to pass have the issue of passing COVID into the community or into their homes.
Okay, and then there's another question for you. Are there any vaccine trials in Austin that your clinic would be willing to enroll folks in that come to your door?
So we're not a part of any vaccine trials right now. We certainly would have an interest if a company or an entity was interested in talking to us about that, but we haven't specifically been asked for that. I would, if asked by a person in my community, because I have been asked, would I participate in one? I would absolutely participate in one if it meant that it was a service to our community and a service to being able to help, as Dr. Wong said, about helping make sure that they're equitable, because we don't have an equitable approach right now to the vaccine studies. And we want to make sure, because I had a conversation with Leah when she first asked me about this, and we talked about a large study that was done around the drug metformin. Metformin had been overused in African American communities for decades. And I took it myself for a while. And my doctor, which I go to the community care clinic, I'm a insured person, but I go to the community care clinic right on Montopolis because the lady that's my physician there is an excellent physician, and I get very good care from her. So she went to a conference and they presented this long study they had done on metformin's use among diabetic patients by race. And there was a large disparity in how metformin had been overused in the African American community. And African Americans weren't necessarily the ones that needed metformin. It was more the folks in the majority community who were, let me see how, because I think they said that the A1C was lower, almost a point lower in African American community, but they were giving it to us because there wasn't any cultural competence around us not having it. So in order to be able to understand that, we have to get communities of color on board first to make sure that they understand how they are helping in service to their community and how they're able to be a part of this. Because if we don't have any representation at the table, then we won't expect the best outcome. It's incumbent upon the drug manufacturers, but it's also incumbent upon us. And I get that there's a lot of mistrust, but we have to start somewhere. We have to start somewhere. We're going to have to be able to have a little window or door to open to do that. And I think as I said, with those public-private partnerships, with folks like me and Director Hayden sitting down at the table and talking to each other about this, I think slowly we can begin to open that door where folks feel more comfortable to be able to participate in these types of things.
Okay, and then this is a question for Director Hayden. 30,000 cases sounds like an awful lot. What do we need to do to bring these numbers down?
Yes, so yes, the total number of cases that we have is 30,601. However, we've had 29,379 recoveries. So actually we're looking at about 780 active cases at this time. And so, you know, we just, as all communities, we track every positive case cumulatively. But we are excited about the recoveries that we've had in this community.
And there are no more questions unless somebody wants to unmute and ask a question directly. Leah, I'm not getting any more questions.
I was just going to ask if the panelists had questions for each other or comments.
Well, I was curious because, you know, it doesn't look like the end is in sight anytime soon. And it doesn't seem like the current administration is very focused or committed to helping people in the near future. And I was wondering what steps y'all were taking to prepare for the next few months, because things move at such a snail's pace in government. You know, like, what are y'all thinking about to tide people over until they can get help, if they even do, you know?
I mean, I'll say, and the thing that we've learned through this is that the community's actions and that the individuals, you know, if they adhere to the universal masking, the 6-foot physical distancing, staying home, avoiding crowds, washing hands, not touching your eyes, nose, and mouth, that works. If people will continue to be vigilant. And so, you know, we're really trying to reinforce that you know, as the state and as the governor's opened up some of the other things, you know, we're not opening the bars. We think we actually just moved our risk transmission level. We have a red, orange, yellow, green color-coded category, and we're just moving it back up to red because we are concerned about the increases in a lot of the hospital numbers, admissions, ICU admissions, and other things. And so we're very concerned with the schools opening, with the colleges coming back, as this weather starts to get cooler and people are spending more time indoors and are getting tired of all this, that there is going to be more increases. So, but we know what we have learned is that there are some of these basic things that can make a difference, that if people do this, we can do more things and open up more safely, but we just have to get everyone pulling together to do that. I mean, we are working on, you know, the distribution plans, or, you know, getting people enrolled to be distributors for the vaccine should it come out. You know, we're continuing to provide other guidance, but it's just going to take everyone continuing to work on it and take it seriously.
Yes, I agree with Dr. Wong. I think, you know, the other thing that we've also emphasized, you know, to our staff is that, you know, we have key folks that, you know, are frontline and are very essential to the response. And so, you know, we've really emphasized the importance of that self-care, doing what you need to do to take some time off, because, you know, this is a marathon. And so, you know, typically with most responses, you know, you set up and you quickly move into recovery. And so we're, you know, what, 7 months in, and, you know, recovery is not anywhere near. And so for that reason, we've really been having folks to think about, you know, taking some time off, you know, spending time away from your cell phones, turning off your emails, doing those things, because those are very important for the workforce, especially within public health. But we also emphasize that, you know, to all of our partners as well, because there's been so many of them, you know, that have been, you know, doing this work as well. It does get to be, you know, we think about the folks that have mental health challenges, and, you know, how it's really important for them. And those of us that may, you know, have folks in our family that may struggle with behavioral health challenges, it's really important for us to, make sure that, we're reaching out to them. We are making sure that they have the support system in place that they need, and they're receiving the care that they need. That has been one of the other areas that, we work very closely with our local behavioral health authority, as well as our partners that provide those those supportive services in the community, because that is really essential. So we think about, holistic health, mental health, as well as clinical health, and your public health from a preventive standpoint, making sure folks are getting their vaccines, because, what we noticed is there were, several folks that were not coming in for vaccines, and folks were not taking their children to get the vaccines. And so all of those things are very important for us to continue to emphasize during this process.
I think that as far as we are concerned, I will be very candid with you. We've been very rigid with our staff and our students, particularly the fact that we have folks who are doing testing and being at the clinics. Any potential student that comes, we want them to go get a COVID test to start before they're enrolled in school to make sure they're negative. We moved to about 75% online learning. So the students are taking all of their didactic courses online. We do have clinicals 2 days a week, and they go to the clinic and work. And like I said, they come home. Our internal staff, faculty and staff, we rotate they sign up for a day of the week to come in. So we don't have everybody on campus all at one time. We have 4 one day, we go in pods of 4. We go 4 on Monday, 4 on Tuesday, 4 on Wednesday, 4 on Thursday, 4 on Friday. And my colleague and I, Mr. Hamilton, were very intentional about when we opened. We provided health insurance for all of our new employees from the very start to make sure that if they contracted COVID for any reason, whether they were working with us or not, they would have the safety of being able to go to a doctor, go to a physician, go to whatever they choose to use as their medical service, to be seen, their families to be seen, their children to be seen, and have that security around them.
I guess that we have no more questions here.
Oh,
Again,
one
I
just
want.
popped into the chat, Leah.
Oh,
Oh, it was just thanks and praise. Appreciate all the information. Thank you to all for all of your work and your efforts to help our Texas communities.
and I would second that.
Yeah.
And also emphasize how enlightening it's been to hear from you all and how hard you're working. I really can see that you're all putting all of your heart and soul into this effort that is really a marathon. It is indeed a marathon, and I don't think any of us expected that. And that's, people are tired. Everybody's tired of it. And I'm sure the healthcare workers are stretched to the max. But yet we have to continue to be really creative and do ever more to continue on the marathon. So thank you all very much for all that you're doing and for taking the time out of your very busy work lives to participate in this program this evening. And we thank you greatly from the League of Women Voters.
Indeed.
Thank you so much.
Thanks, everybody.
All right, bye-bye.
Bye.